Minutes or so, I'm going to give you an overview of keratoconus and kind of go over what we know. And if you have any questions, please feel free to raise your hand or shout out. I'd love this to be interactive, and I'd love to be able to address any questions that you might have. Okay, so keratoconus. I'm sure most of you know that this is a disease of the cornea, where you have thinning and protrusion in the shape of a cone, resulting in an irregular or lopsided shape. This picture up here is a corneal topography. How many of you have seen your own corneal topographies? Good, a very proactive and knowledgeable group. And you probably know that irregular topography maybe looks more like greenish and bluish, and maybe yours might have some yellow or orange or red on it, and it looks a little bit scary. So this is a map that essentially shows where the steepest part of your cornea is. And here's an example of what keratoconus may look like. It's often asymmetric, meaning that one of your eyes is probably worse than the other. It's protruded more, it's thinner, you might have more scarring there, and you may see better in one eye than another, and that's very, very normal. This condition usually starts in the teens, around puberty, and then tends to progress through the 20s, and usually, in my experience, but not all the time, tends to stabilize in the 30s. And this becomes important because, as you'll hear a little bit later, there have been some new treatment options available in the form of cross-linking, and depending on which level you're at or which stage you're at, you may or may not be a good candidate for that. This condition, as you well know, causes vision distortion and blur. So when this condition starts, generally in the teens, if it's mild, many people may be correctable with glasses, sometimes soft contact lenses. As it progresses, this is where you may need to look into different forms of treatment, such as rigid gas permeable contacts, hybrid lenses, scleral lenses, or some other form of vision correction. And early on, patients may not know they have this condition, but do know that they had a lot of astigmatism. They just had thick glasses, and eventually my optometrist or ophthalmologist couldn't give me glasses anymore, and they didn't really know, and finally I was diagnosed with keratoconus. So this is what a normal cornea looks like. The cornea is the clear tissue in the front of your eye, and that's where it becomes irregular, like the shape of a cone in keratoconus. The prevalence of keratoconus actually varies widely depending on the country and geographical location. It can range from 0.5% up to 2%, depending on the country. There's definitely a lot of patients ask, how did I get this? Is it genetic? Was I just born and I was going to get it no matter what? Or did I cause it? Did my parents give it to me? Well, there is definitely a genetic component. It's not always predictable, but there is some familial inheritance. It can be autosomal dominant or recessive. In many of my patients, I just had one this week where it was a male patient and his father had keratoconus, but to a much milder degree. I've had brothers, I've had patients where their aunt or uncle or cousin also have keratoconus. So there's definitely some genetic component. And if you have keratoconus, it doesn't mean that your children are going to have it, but it does mean that you need to be more careful. Take them in for regular eye exams when they're becoming teens or even earlier. They might have a higher risk, but doesn't mean that they'll have it. Many twins may have it. There's no specific gene mutation that has been identified that leads to keratoconus, but there's definitely a lot of research going on to identify these affected genes. In terms of environment, can that affect your development of keratoconus? Well, sometimes contact lens wear, if it's maybe not the optimal fit and it's rubbing and rubbing and rubbing, it can be causing irritation that may lead to more progression. Chronic eye rubbing is not good. And a lot of keratoconus patients, I know, you probably don't tell your doctor when they ask, but You guys love to rub with your knuckles and rub really, really hard, especially when you take out your contacts or like maybe when you just wake up. And I've suffered from that this past week because my allergies have been really bad, and I've been rubbing and rubbing, and every time I think, oh my gosh, this is what all my keratoconus patients are doing and trying not to do. So rubbing your eyes does cause the release of inflammatory mediators that can, if you rub and rub, weaken an already weakened corneal tissue. So do your best not to rub. There are some over-the-counter medications. There are prescription medications. Often refrigerating your eye drops and using them cold can help with the itchy sensation. And cold compresses sometimes can help as well. So, and a lot of my patients actually who wear RGPs or sclerals tell me that when they wear their contacts, they know they can't rub their eyes because their lens will fall out. So maybe it's a good thing if you're wearing contacts. And allergies. If you have allergies, please have your doctor evaluate your eyes and get treated, because it's miserable to be itchy, and it's not good for your corneas either. So what does a keratoconic eye look like? How many of you have seen a picture, not a topography, but a picture of your cornea? Good, good. And your doctor may have pointed out to you some corneal scarring. And this is what contributes to the decreased vision. So here's a picture of one of my patients with pretty central corneal scarring here. And when I started working at USC, oh, I guess I forgot to introduce myself. I work at the USC Roski Eye Institute in Los Angeles, and I've been there for about 9 years. And I mainly fit specialty contacts for patients with irregular cornea, such as keratoconus, and dry eye patients. And prior to me being there, I spoke with a lot of my corneal specialists and corneal surgeons. They were moving to corneal transplantation a lot sooner, many, many years ago. But now with scleral lenses being available and better contacts, part of their routine before doing any surgery is sending for a contact lens consult to see if vision can be improved and their quality of life can be sufficient without surgery. So this patient, probably 15 or 20 years ago, would have been told they need a transplant. Your scarring is so central, there's nothing that can be done to improve your vision. Well, this patient was actually a doctor, and we put a scleral lens on, and he was seeing close to 20/25 even with this scarring. So even though it can be central, it doesn't mean that your vision won't be improved sufficiently with a contact lens. So remember that, and a lot of the surgeons now, they do understand that and do work with their optometrist to make sure that there isn't another alternative before transplantation. So this is definitely scarring. You may also see these little vertical marks that they look like stretch marks. And that's because the corneal tissue, the layers are being pushed beyond what they can handle. You have thinning, and sometimes you may see this brown ring kind of in the mid-peripheral region. That's called a Fleischer ring, and those are iron deposits that land at the base of where the cone is. So that's what an eye looks like. Earlier I mentioned there's some genetic component. There's also several associations with systemic disease and systemic syndromes, such as Down's, Leber's, and other connective tissue disorders. So you want to make sure that you're working with your other doctors as well. Eczema is very, very common in keratoconus patients. I see their skin, sometimes on their face, around their neck can be rough. They have patches on their arms and legs. Definitely work with a dermatologist who might be able to offer some creams, lotions that can help with skin, outside of your eyes if you're having itchiness. And eye allergies, as I mentioned earlier, there are many treatment options and drops for ocular allergies. So please consider getting that treated. Otherwise, you may see little bumps like this on your eyelid. They don't look very pretty, and they don't feel good either. So when your eye doctor is looking at your eyelids and sees these bumps, they may prescribe something for you. So A question that I hear often from patients who were just diagnosed with keratoconus is, will I become blind? It's a very valid question. It's scary because maybe you don't know much about this condition, and you worry, is this going to affect my ability to get a job? Am I going to work? Am I going to be able to have kids, raise a family? So they kind of, maybe they don't want to ask it, but I know they're kind of thinking, will I become blind? So my answer is, and it's good news, it is very unlikely that you will become blind because there are so many good treatment options today and newer options that have just come out in the last few years that will allow you to improve your vision. Non-surgical and surgical. So glasses, for many patients with mild keratoconus, work perfectly fine, and many people are able to wear glasses for their whole life and function very well. Contact lenses, soft, there's the RGPs, there's hybrids where there's a rigid center and a soft skirt. There's scleral lenses, many types of scleral lenses. And iPrint Pro, which has come out within the last few years, where you actually take a mold of the eye to make a custom lens. And Dr. Vivian Shibayama, who's going to be a speaker later today, will talk probably a little bit more about that. She offers that at Jewel Stein. And if you're unable to get your vision corrected sufficiently with any of these forms, that's when your optometrist may send you to your ophthalmologist for a surgical consult. The good news is that corneal surgery has also advanced a lot in the last few years. And also, it's important for you to know that only 15 to 20% of keratoconus patients actually, require surgery later on. So it's not the majority that will end up having surgery. And so usually, patients who develop very advanced keratoconus at a young age. So if you're a teenager and have very advanced keratoconus, you may want to, start looking at those options earlier. There are full thickness transplants and also what we call partial thickness transplants, where they can only remove a part of your transplant. And that's less risky and has less side effects and complications. And again, surgery is only to address really the severe scars that you might have for contact lens intolerant patients. So maybe they can wear glasses or soft contacts. But it's important to know that after surgery, the majority of people still need contacts. So don't think that I'm gonna have surgery, my vision's gonna be 20/20, it's gonna be like LASIK, and I'm gonna come out seeing 20/20 the next day. That's not the case. So I just want you to have a realistic knowledge of what might be to come. So these are RGPs. I just wanted to show you some pictures. How many of you wear RGP contacts? Good. And usually for maybe milder cones or very tolerant patients, these work perfectly fine. They sit on the cornea, they do move a lot more. The only downside is that if you get dust in your eye, or if it's a windy day, or you're looking off to the side really quickly, they may fall off, or if a little piece of dust gets in, you may feel like there's like glass in your eye and you're kind of like debilitated. So that's the big challenge, I think, with RGPs, but I have many patients who wear RGPs and they're very happy and they have really good comfort for decades. So definitely an option. Sometimes when the shape of the cornea gets too distorted, the RGP fittings get more complicated. You can see with these bubbles, which is called dimple veiling. Sometimes the cornea is so steep that the edge of the contact just rides so high that your lid sometimes kicks it out. So when you develop challenges where RGPs don't work anymore, that's when you may consider hybrid or scleral lenses. This picture here just kind of shows you a gas permeable lens is in the range of about 8 to 10 millimeters. Soft lenses are bigger, they cover the cornea. Then you have lenses called corneal scleral lenses that range from about 14 to maybe 16, you get into a semi-scleral. So some of these can work. I personally prefer the larger ones. So I took this picture of some of the lenses that I have in my office. This is a 16, a 17, an 18, a 19, and that's a 21. And for patients who had very, very severe ectasia, or sometimes something called keratoconus, or maybe pellucid marginal degeneration, which is a variant of keratoconus, larger lenses, they look scary, but honestly, they're comfortable and they can work very, very well. It's challenging in the beginning learning how to get these big hunks of plastic in your eye while balancing the fluid. And there is a learning process and learning curve, but once you learn it, it can be very, very helpful for you. Any questions about anything so far?
Question.
Yes.
For your patients who do have corneal transplants, what's the rehabilitation time that you would typically tell them that you would then be able to fit them?
That's a great question. So it depends on if they're having a penetrating keratoplasty, like a full thickness, where they've had multiple sutures put in and their ophthalmologist is removing the sutures. That process for a full thickness transplant can take up to a year. If you're doing a DELC, which is only removing the front part of the cornea, the healing process is much faster. So I would say it varies. It could be usually no sooner than 4 months, and it can be up to a year. And so I always tell patients, if you're going to have a transplant, keep in mind you may not be able to go back to work the next day because your eye's going to be inflamed, red, sore. It's an invasive surgery, and you might not be able to see well out of that eye for a few months until you can be refit with a contact. So it can be a few months. I have had the privilege of being able to work with Boston site based out of Needham, Massachusetts, and I provide Prost treatment at USC. And this is essentially a larger type of custom scleral device. It sits on the scleral tissue and vaults the entire cornea. This isn't for everybody. Sometimes RGPs, various scleral lenses may work perfectly fine for patients, but if patients are very sensitive or very, very steep, this might be an option if they couldn't adapt to other types of scleral lenses. And you can see how far it extends beyond the cornea itself. And this is what you don't want. You don't want these little bubbles there. I'm sure many of you have experienced that. If you get these bubbles, you have to take the whole thing out and reapply it on your eye to improve the vision. So prevention, one of your speakers later today, one of the corneal specialists is going to be speaking about this, so I don't really want to give away too much. But corneal cross-linking has been FDA approved in the United States within the last year or so. So a lot of institutions, including here at UCI and UCLA and USC and many private practices, are offering this treatment. And it involves using UV light and a special vitamin called riboflavin to stiffen the cornea. But as I mentioned earlier, keratoconus tends to stabilize in the 30s. And so if you're stable, you don't need to have this treatment done. But if any progression is seen, and it tends to be in the younger and more mild cases, this is definitely something that's been done in Europe for decades, actually. And we're just starting to get into it here in the United States. So something that you're going to hear a little bit more about later. So this is my information. I forgot to introduce myself, but my name is Gloria Chiu, and I'm the director of the optometry service there. I also work with the optometry school in Fullerton, the Southern California College of Optometry. We get a lot of optometry students and interns and people who are interested in the profession volunteering with us. So it's really fun to be teaching these people. I just want to, I guess that other slide didn't make it on here, but I did also want to mention there is a organization called the Scleral Lens Society. I'm a fellow of that organization. Dr. Vivian Shibayama, who is speaking later, is also a fellow of that society. And I want to say the website is scleralens.org. You can probably just Google a Scleral Lens Society. There's a lot of great resources for doctors, patients as well, about scleral lenses, about practitioners in your area who might be fellows, more familiar with the scleral lenses, and videos and just information that might be helpful to you as patients.